Good morning, everyone. It's a pleasure to be here in this very beautiful city and with all you beautiful people. It's also an honor to be here with on the same panel as Andrew and Moses, who their work has really inspired me to also focus on this area of TB and its impact on cardiovascular disease. A few learning objectives for today's talk. I'm hoping by the end of this presentation that you will be able to summarize some key data on the relationship between TB and its impact on cardiovascular events, mainly epidemiologic data, as my background is in epidemiology, and then to broadly describe some limitations of those studies in terms of our ability to make causal inference on the relationship between TB and incident cardiovascular events. I'm going to try and keep this to 10 minutes. I heard a rumor that Andrew has 100 slides to go through, so I'm going to keep this short. All right, so this morning I'll start off with a slide about limitations and challenges to frame this brief talk. Although personally it's not hard to convince me that TB causes nearly any non-communicable disease, there are certainly skeptics, and maybe primarily outside of this space, that a TB-CVD relationship actually exists. And of course, skepticism in all epidemiologic studies is certainly warranted, but in studies that attempt to estimate the impact of TB on cardiovascular disease incidence, a key limitation is to find a control group that appropriately represents the counterfactual experience of having TB, which of course is not an easy challenge to overcome. In addition, studies to date are primarily or exclusively observational. So the studies that have looked at TB and cardiovascular disease are either cross-sectional or rely on retrospective cohort data. So a major limitation to retrospective cohort data is relying on things like ICD-9 codes and other indirect measurements of cardiovascular disease instead of direct biologic measures. And unfortunately, or fortunately, depending on your perspective, we'll never be able to randomize people to get TB. So future studies will also be observational in design, right? That's not to say we won't be able to improve on inference about the effect of TB on cardiovascular disease risk, but really it just means that we're going to have to do more studies and have them replicated in more environments in order to make causal inference. All right, so hopefully you're all skeptics now. But I will try to move on and convince you that indeed the data that we do have that is epidemiologic in nature anyway suggests a causal relationship between having TB and increased risk of cardiovascular events. All right, to begin with a summary of the data, I'll share a slide from an excellent meta-analysis that was done by Andrew Basham. Camilla was involved in this as well, and Jay Johnston's group out of Canada. So this was a meta-analysis published in 2020 and looked at studies that consistently measured TB using the same definition as well as either cardiovascular event or cardiovascular death. And so you can see on the forest plot here, there is quite a bit of heterogeneity, but every single study that was included in the analysis showed an increased risk of cardiovascular events in people with TB compared to their non-TB control. There was another study, a great study done in Korea that didn't get included in this meta-analysis because it was published after this. But overall, you can see the pooled estimate for the association between TB and incident cardiovascular disease is about 1.5, suggesting that the risk of the risk of cardiovascular events or disease in patients with TB is approximately 1.5 times the risk in those without TB. Okay, so now I'd like to move on and talk a little bit about a recent publication that I worked on in collaboration with colleagues at the St. George's University of London, Julia Critchley. This was a retrospective cohort as well that also used ICD codes primarily to measure incident cardiovascular events. The advantage of this study, though, over previous retrospective cohorts is that we were actually able to follow people prior to TB diagnosis. So we followed a cohort of almost 20,000 people, close to 20,000 people with TB, and 10 matched controls. But we actually followed them, as I mentioned, 2 years before their TB diagnosis to observe incident cardiovascular events. Okay. So this study design is a little bit complicated and a little hard to follow, so I'm just going to actually jump straight to the results in the graphical form, which I think is easier to follow. On the x-axis is the time in months since TB diagnosis. So that green vertical line represents the date of diagnosis of TB. The y-axis is CVD incidence per 1,000 person years. The red line is those people who have TB, and the blue line is controls. So you can see even in the pre-TB phase, like 2 years prior to TB diagnosis, people with TB actually had an increased risk of cardiovascular disease. That risk has a peak around the time of TB diagnosis, but it's clearly highest in what we call the acute phase, which is the 4 months before and 4 months after TB diagnosis. And then also important to note that that elevated risk of cardiovascular events remains after TB, but does return somewhat back to original differences after about 2 years. So that was data on the left-hand side from the United States. On the right-hand side is the UK. So another key advantage of this study design is that we replicated it independently in 2 different cohorts, and we found almost the same result. The main difference between the right and the left, besides the location and the data, is that the y-axis in the UK is on a different scale. The UK database was much more representative of the entire population, so it had a much younger cohort compared to the US VA population, which is much older. All right, so this is just the data in the table format that I presented on the graph. The only real thing to highlight here, so in the rows are the incidence of cardiovascular disease at the different time periods, so again from 2 years before all the way to 2 years after TB diagnosis. And you'll note that patients with TB had increased rates of cardiovascular events in every single one of those periods compared to controls. And then on the far right column, the other key advantage of this study over other retrospective designs is that we were able to adjust for baseline differences in cardiovascular disease risk. So going back to that previous slide, in that far left panel where it's the pre-TB, we actually adjusted for that period of difference. So the far column represents the increased risk of cardiovascular events in people with TB compared to matched controls on age, sex, study clinic site, as well as a host of other factors like BMI, smoking, HIV status, hypertension, use of medications. And so, that's the real advantage of this, I think, is we had a good control group and we were able to account for baseline differences in potential cardiovascular disease risk, isolating more effectively the impact of TB. UK, again, had practically the same results. Okay, shifting gears again, one of the most exciting things for me about coming to this conference is to learn about new prospective studies. So as I mentioned, I feel what this discipline needs, the TB CVD area it really needs is more prospective cohort studies that are designed specifically to measure cardiovascular impacts. So I'm just highlighting 2 posters from our group, but I know there are at least 5 others from other groups, so I'm really excited to see new data coming out in this area. And I encourage you to look at Argita's poster, which was a prospective study conducted in Tbilisi, Georgia, where we work, and she was following participants at the end of treatment for 12 months to look at the increases in metabolic syndrome after TB, comparing by the weight change during TB treatment. Another one, also from the country of Georgia, will be presented by Jigbordi. This is another ongoing prospective cohort study in the country of Georgia looking at stress hyperglycemia and its impact on post-TB cardiometabolic measures. And specifically in the first 6 months after TB, we've seen substantial increases in key measures of cardiometabolic risk, including blood pressure, hemoglobin A1C, visceral adiposity index, increased insulin resistance, and decreased beta cell function. So those are just teasers. Please see the posters this afternoon. So, all right, 2 more slides. One is to focus on what the data do not yet tell us. So there's important to still understand the fact of TB infection and other subclinical forms of TB on cardiovascular disease risk. There is some data on that, and I think we'll talk about it this afternoon in the workshop, but more work needs to be done there. And we also don't have any understanding really of the long-term impacts on cardiovascular disease risk among those who had TB at a young age. The other key problem is to disentangle other strong risk factors for CVD incidence that co-occur with TB. So understanding the multifactorial causal relationships with CVD among TB patients, and trying to understand what proportion of all cardiovascular disease is due to TB. Given the ubiquitous, almost ubiquitous nature of TB infection, I think this is something that we don't understand as well. And then related to intervening, Brian said yesterday acutely or accurately that we don't really know how to intervene for NTP programs on preventing PTLD. That's one thing we do know, at least temporarily. We have a lot of preventive programs that have tried to look at the effect of preventing CVD, but we do need to do that specifically in TB patients. All right, so in summary, I'm hoping that I've somewhat convinced you that existing observational data consistently show a strong relationship between having TB disease and increased risk of cardiovascular disease. Some of our early data also suggest that that risk may be greatest during the acute phase, so right around the time of TB diagnosis, but also persists even after successful treatment. And I already, I think, talked a little bit about all these knowledge gaps. So I don't think I will repeat those knowledge gaps in the interest of time. Thank you.